Great, so we're live.
Good morning, everyone. Good morning, everyone. Welcome to Cardiology Rounds. I'm going to introduce Dr. Chong, who will introduce our speaker this morning and the topic. Dr. Chong.
Hi, good morning, everyone. So this morning we have Mohammad, who's our PCI Fellow, who'll be talking about a topic that's close to my heart. You should say intracoronary physiology and the use of it to optimize PCI, as well as its more recent applications in microvascular disease. So over to you, Mohammad.
Thank you, Dr. Chung. I'm just trying to share my screen here. Are you able to see my screen?
Yeah, we're seeing a screen.
Yep.
Yes, go ahead, Mohammad. Okay. This is great.
So thank you for asking me to present today at Grand Rounds. My topic for today is optimization of PCI with intercoronary physiology. I would like to thank Dr. Anyang Chung for helping supervise the talk and helping me with my slides. So today I'm going to briefly discuss the history of intercoronary physiology and then go on to discuss how to perform hyperemic and non-hyperemic measurements. After that, we're going to be talking about the use of intercoronary physiology pre-PCI in stable patients in non-culprit lesions in ACS, using physiology to assess left main, pre-CABG, and CABG versus PCI in the FFR error. And then we're going to be talking about the use of intercoronary physiology and optimization of PCI afterwards by stent optimization and assessing whether a sideband needs to be treated or not. And we leave the last 10 to 15 minutes to talk about the intercoronary physiology of coronary microvascular dysfunction. So in regards to history, this is Dr. Grunzig. He published a paper in 1979 about the first POBA done. And he was a big advocate for using intercoronary physiology. He had a transducer measuring pressure at the end of his guide catheter and another pressure transducer at the end of his balloon tip. And he has noticed that once a lesion is crossed, there's a big pressure gradient between his aortic pressure and the pressure distal to the lesion. And he has documented that once this lesion is treated with balloon angioplasty, the pressure gradient resolves. And he was the first one to theorize that the dissipation of the pressure gradient means a great result in terms of achieving a good flow and a good outcome for the patient. There was a couple of problems with the use of this technique. The biggest one was his balloon catheters were about 2.8 French to 3 French, meaning if a not necessarily significant lesion is crossed, this could cause significant pressure changes. So his technique was not taken on early in the phase and slowly started developing afterwards. If you look at this paper published in 1974, they documented that once you reach 80% luminal stenosis, resting flow is decreased. However, if you have a moderate lesion between 40 and 80%, you can start seeing that the coronary flow reserve starts slowly decreasing as the stenosis gets worse. And this is because of fluid mechanics of a stenosis. The most significant factor in determining flow is the minimal lumen area. The next factor would be the length of the lesion. I'd like to also point out that once a lesion is stenotic enough, it will cause turbulence in flow post-stenosis. So when we're doing intercoronary physiology, the wire has to be placed at least 5 to 10 millimeters distal to the stenosis, so you're not catching the turbulence, but you're catching laminar flow after the stenosis. If you look at the number of PubMed papers published each year with FFR in their title or abstract, this has exponentially grown over the last decade, starting with probably 5 to 10 papers, and now we're averaging more than 200 papers, especially after FAME 1 and FAME 2 came out. So I'd like to start my talk with 2 cases where intracoronary physiology makes a difference in your management and outcomes. So case 1, this is a 65-year-old female with a NYHA class 3 symptoms. She has an inconclusive exercise stress test, admitted for an invasive coronary angiogram. You can see the angiogram on the left side of the screen showing the left coronary system, LAD, and circ. There's a moderate lesion in the LAD, and the significance of this lesion is unknown, so intercoronary physiology will help guide whether to go ahead and PCI this lesion or defer. The next case is a gentleman that's 54 years old with typical angina, progressive over several years, comes in with multiple risk factors: smoker, dyslipidemia, hypertension, presented to the emerge 3 times over the last 8 weeks. Every time he gets discharged, because his troponins are negative, his ECG is negative. On his 3rd visit, it was decided to go for an angiogram. And as you can see, this is his right coronary artery, quite tortuous, but the flow isn't normal. The flow is sluggish. I'll play this one more time. And this is his left coronary system. Again, tortuous arteries, flow is sluggish. It's not the brisk normal flow you would expect for a young 56-year-old with no obstructive coronary artery disease. So I'll discuss each case separately. So we'll start with case 1. So how to perform intracoronary physiology and what's the limitation to a 2D angiogram. Well, the coronary is a 3D structure, and we're moving or changing a 3D structure to a 2D structure. So to fully assess a lesion, you need 2 orthogonal views. But despite that, significant lesions can sometimes be missed because you're not getting the right angle. And this is the where intercoronary physiology is very helpful in deciding whether a lesion is significant or not. So how to perform intercoronary physiology? You'd first start with a guide catheter intubating the ostium of the coronary artery you want to interrogate. Then a guide wire is passed until the transducer is close to the guide catheter, and you have to equalize the pressures to make sure that these pressures are equalized well. After that, the pressure wire is manipulated to pass through the lesion, and as I said, it has to be at least 5 to 10 millimeters post-lesion, and the further you go, the better. And then you have a resting PDPA gradient. Once that's done, you can start measuring your non-hyperemic pressures by using softwares depending on which company you're using. After you've achieved your non-hyperemic measurements, you then induce hyperemia, first by giving intracoronary nitroglycerin to cause epicardial dilatation by 200 micrograms intracoronary. And then you have to cause microvascular dilatation by inducing hyperemia. And there are multiple agents that are used to induce hyperemia, the most common being either IV or intracoronary adenosine. And what you want to achieve is the picture on the middle of the screen here, where you get ventricularization of your curve. And this is to show that you've achieved good hyperemia. What you don't want to see is pressure dampening, the image on the right, where your catheter is wedged into the ostium of the artery. This will give you a false reading. So you have to disengage your guide. And this is why you don't want to use a catheter with side holes, because then the pressures might not be accurate. Once you've induced hyperemia, achieved your measurement, the wire needs to be pulled back to make sure that there is no drift. If there is drift, the study needs to be repeated again. So just some pitfalls in measuring FFR, because you're only accurate as your readings, and this has to be performed well. So going back to our first case with the moderate lesion in the LAD, the wire was passed through the left main, equalization was achieved. The wire was manipulated past the lesion and 200 micrograms of intracardiac nitroglycerin was given. IV adenosine was started, and after 2 minutes, you can see that the PD pressure has achieved hyperemia, and the FFR was 0.69. So it was deemed significant. So while adenosine is running, we wanted to confirm that the pressure gradient is true. So the wire is pulled back, and as you can see here, once the lesion has been once the wire has been withdrawn past the lesion, there's a jump in pressure, meaning that that lesion was significant. To reconfirm that the lesion is significant, and this is a true reading, not an artifact, the wire was repassed through the lesion, and you can see a drop in pressure again, signifying that this is a focal lesion, which is a great lesion to treat with PCI, and the wire was withdrawn back. And at the end, the wire was parked at the ostium of the left main to confirm that there is no drift, and this is a true reading. So PCI was performed for this patient. The other thing that we could use is a non-hyperemic pullback with co-registration. And this is done exactly the same as you would do for an FFR pullback, but here you have the advantage of co-registering. And the nice thing about it, it shows you where significant pressures have been, significant changes in pressure. Each yellow dot is 0.01 difference in pressure. And as you can see here at the proximal LED, this is where the biggest pressure drop is. So this would guide your PCI. So in regards to today's talk, I'm going to be discussing the FFR non-hyperemic measurements to assess epicardial arteries, whereas we're going to be talking about IMR to assess the microvascular system. So in terms of assessing epicardial arteries, there's multiple measurements we can take, but FFR is the gold standard with multiple randomized controlled trials. And then we'll talk about IFR since it has the most RCTs in regards to the non-hyperemic measurements. So the big trial for inducing hyperemia and measuring FFR is the deferral trial, where they studied 325 patients and they randomized them into 3 groups. The reference group had a FFR that was strongly positive, less than 0.75, and PCI was performed. And the other 2 groups had a non-significant FFR greater than 0.75, and they were categorized into 2 groups, either to defer PCI or perform PCI. And if you look at the image on the right-hand side of the screen, looking at the outcomes for 2 years, the percentage of patients that were event-free, the best patients, or the patients that did the best, were patients that had their FFR negative lesions deferred. And then if you look at the 5 to 15-year outcome data for the deferred trial, showing that this benefit continued on for up to 15 years, patients that had a non-significant lesion by FFR did better than patients that had PCI done on these lesions that were not flow limiting. Fame 1 came afterwards, looking at the same population. It was about 1,000 patients looking at FFR-guided PCI versus a angiogram-guided PCI. This is the 1-year outcome data of Fame, showing that a FFR-guided PCI was superior to an angiogram-guided PCI in terms of MACE afterwards. If you look at the 5-year outcome of Fame, was similar to the first-year outcome, and it showed that a FFR-guided PCI versus an angiogram-guided PCI was superior as a strategy. And then if you look at Fame 2, in which FFR was used to guide PCI versus medical management and stable coronary disease, these patients all had FFR positive, and they were testing whether PCI plus optimal medical therapy versus optimal medical therapy would cause a difference. And as you can see, there's a statistical significance in terms of urgent revascularization for patients within 1 year if they were randomized to medical therapy alone, meaning that if you had a significant lesion that is FFR positive, you did better with PCI and optimal medical therapy rather than just optimal medical therapy alone. And if you look at the 5-year outcome data of Fame 2, it showed similar results. Patients did better with FFR-guided PCI. 'I' and medical therapy versus medical therapy alone. So some patients are unable to tolerate hyperemia induced by FFR, and this is why it was important to have another modality to measure better pressure gradients without inducing hyperemia. And that's because of the multiple side effects of adenosine: flushing, dyspnea, chest pain, headache, AV block, and bronchospasm. So if you have a patient with severe asthma, adenosine is not the best drug to give them in the cath lab. Or if you have a patient with severe aortic stenosis, you don't want to induce hyperemia in these patients. So it was important to have another modality to measure pressure gradients. So the RESOLVE trial looked at whether IFR results are similar to FFR results in terms of significance. So they tried to examine the accuracy in about 1,768 patients. And they found out that IFR is about 80% accurate when you compare it to FFR. So this was not enough. We needed a randomized controlled trial looking at hard outcomes and see if there's a difference. So the IFR Sweden Heart investigators looked at that. They randomized about 2,000 patients to FFR-guided PCI versus IFR-guided PCI, and they looked at MACE. And as you can see the image on the right, there is no statistical significance in terms of FFR versus PCI. And this is the DEFINE FLAIR study showing similar results in about 2,500 patients, and they concluded that IFR showed similar results in terms of FFR-guided PCI in regards to MACE, so there was no statistical significance. So either one could be used to assess a lesion. So this is where this algorithm was created afterwards. If you had a angiographic moderate lesion between 40 to 90 or even 40 to 80 stenosis in a non-ACS, you can check IFR. And the IFR cutoff depends on whether you have symptoms of ischemia or testing consistent with ischemia. So if you have clinical symptoms of ischemia or non-invasive test consistent with ischemia, you only need a positive IFR to lean towards PCI, whether if otherwise, if patient does not have convincing symptoms or does not have a non-invasive test, then a lower cutoff of IFR is used at 0.86. If the IFR is strongly negative, meaning an IFR greater than 0.93, then optimal medical therapy can be used. If it's borderline, you can consider FFR to confirm whether this patient should undergo PCI or not. That being said, most operators are more comfortable with using FFR than IFR because the wealth of data is still in the FFR group. What about using FFR in non-culprit lesions for ACS? Is it safe and can it be helpful? Well, I'll give you the appropriate results. So the Dynamic 3 Prime Multi trial looked at that, where they randomized patient to culprit-only PCI versus FFR of non-culprit lesions. And they looked at the STEMI population with multivessel disease, looking for complete revascularization by FFR. And they found that complete revascularization by FFR was superior to infarct-related artery only. So this study proved 2 points. One, it's safe to and accurate to complete FFR measurements on patients that are presenting as STEMI. And two, it showed the importance of complete revascularization, as we've seen through multiple trials. The results of that trial was also, the COMPARE-IQ trial showed similar results, where they randomized about 885 patients to FFR-guided complete revascularization for infarct artery-only treatment, and showed similar results. Complete revascularization guided by FFR is superior to just treating the culprit artery. In terms of use of intracoronary physiology for left main, there's a couple of limitations for using intracoronary physiology for assessment of left main, and we'll go through them. So the biggest confounder for assessing left main disease by FFR is whether you have an isolated lesion or you've got multiple lesions, because if you've got multiple lesions, the FFR will measure the gradient through all the lesions at once. So it's great for assessing patients that have isolated left main lesions, you can park the wire in the LAD or in the circumflex artery and you will get accurate result. The problem is most patients that have left main disease, about 70 to 80%, have multi-vessel disease. So the issue is where to park your wire. Do you park your wire in the LAD or the circ? The problem is if you have a lesion in your LAD and you park the wire into the LAD, then you might get a possible false positive because you're measuring the gradient through two stenoses and you're not measuring the gradient through the left main alone. Whereas if you park the wire into the circumflex artery, it might be a possible false negative because of the increased flow through the circumflex artery because of the tight stenosis in the LAD. So it becomes very difficult to assess patients with physiology looking at multiple lesions, where you're trying to assess whether the left main is significant or not. That being said, if you looked at the data for patients with isolated left main stenosis, this was a study published in 2001 looking at whether the FFR is positive or negative. So if you had a FFR that was negative, you were deferred from revascularization and kept on the medical group. Whereas if your FFR was positive, you were sent for surgery. They looked at about 50 patients in each arm. And as you can see, there's no difference in outcome over 3 years if you had deferred revascularization and a FFR negative left main. So we needed another modality to assess patients with left main disease with that had multi-vessel disease as well. So this study was published in 2004 where they did FFR measurements and IVUS measurements, and they looked at the positivity of FFR, and they found out the cutoff area for a minimum lumen area of the left main to be 5.9 to be sensitive and specific at 93 and 94% with a positive FFR. And if you look at their data here, you'll see the plot between FFR and the minimum lumen area. So they've concluded if your MLA is less than 4.8, then you're more likely to have a significant FFR left main, whereas if your MLA is greater than 6, you're more likely to have an FFR that is negative. It becomes difficult to assess lesions where you're in the intermediate range between 4.8 and 6. And this is why they there's multiple reasons why this could be happening, and this is the biggest one. If you have a gentleman with a body surface area of 2.2, a left main with a measurement of 6 millimeters squared is going to be too small for this gentleman, and this is most likely to be FFR positive. Whereas if you have a female with a body surface area of 1.5, a left main with a 6 millimeter diameter or area is sufficient for her, and the FFR would be negative. So it became important to have an algorithm to assess patients with left main. So if you look at this algorithm, if you had a MLA less than 4.5, then this is definitely significant and the patient should undergo revascularization. Whereas if their MLA is greater than 6, you can defer revascularization and continue with conservative management. Whereas if your MLA is between 4.5 and 6, revascularization should be, if you have an intermediate MLA, then intracardiac physiology should be assessed, and if the FFR is positive, the patient should undergo revascularization, whereas if it's negative, patient should continue with medical therapy. I'd also like to mention that there are multiple cutoffs depending on which region you live in. So if you live in North America, the cutoff is about 6, whereas if you live in Asia, and especially if you look at the Japanese data, they only consider a MLA of about 4.5 to 4.8 significant, and they defer revascularization for anything above, and that's just because of looking at the body surface area of the populations. In terms of using FFR for pre-CABG, this is a prospective registry data looking at FFR-guided CABG versus angiogram-guided CABG, and was conducted between 2006 and 2008 in a prospective fashion 429 patients underwent angiogram-guided CABG, whereas 198 patients underwent FFR-guided CABG. And if you look at the results, the patients that were in the FFR group received fewer grafts, fewer anastomosis, lower rates on pump surgery. And their outcomes was that the lower number of grafts did not result in an excess hazard during and up to 36 months of follow-up and was associated with a lower rate of angina. This was the IMPACT trial, which is a study conducted here in Ottawa. 67 patients in a multi-central trial assessed by FFR pre-CABG, and they showed that a significant association between the preoperative FFR measurement of the target vessel and the anastomotic functionality at 6 months, with a cutoff value for the LAD of 0.78. So even FFR lesions pre-CABG is helpful. The last study I want to talk about for CABG versus PCI is the FAME-3 trial, which is an ongoing trial. And the aim is to determine whether FFR-guided PCI in patients with multivessel coronary artery disease will result in similar outcomes to CABG. Their estimated enrollment is about 1,500 patients, and their estimated completion date is 2024, and will help us guide whether FFR-guided PCI is as good as CABG. So you've assessed patients with angina, you've done the PCI, was FFR positive, but the patient is still complaining of residual chest pain. And this is seen in multiple data, multiple studies, that residual angina after 1 year after PCI is present in about 20 to 30% of patients. So how can we improve this outcome? How can we treat their angina better? And I think this is by optimizing our PCI results. So there's multiple modalities you can use in terms of assessing or optimizing your PCI, whether that's by physiology or intracoronary imaging. I'll focus my talk today just on the FFR post-PCI. So if you look at FAME-1 and FAME-2 data, where they measured FFR pre and post PCI, but did not act on the results post-PCI, as you'll find that about 30% of their patient, 30 to 40% of their patient had an FFR less than 0.9, and about 25 to 30% of their patients had an FFR less than 0.8, meaning that if these patients went into the study, they would have been randomized to PCI. So we're not getting the optimal results of intercoronary physiology even post-PCI for about 20 to 30% of our patients. Another study that showed similar results is the DK-CRUSH-7 trial. This was a registry data of about 1,478 patients who underwent FFR-guided PCI, and FFR assessments were done post-PCI. And if you look at their 1 to 3 year follow-up for their target vessel failure, you'll notice that the lower your FFR, the worse the patient's outcome are. And they concluded the study by saying that a post-drug-eluting stent FFR less than 0.88 strongly correlates with target vessel failure. There's no approved cutoff yet, and we're still doing more studies to define what is the best cutoff for deciding whether more optimization needs to be done. But if you look at the defined PCI trial, where they randomized about 500 patients after successful PCI to optimization by angiogram or IFR, they found residual ischemia after the operator has deemed that this is an angiographically successful PCI was present in about 24% of patients, with an IFR in that population being on average of 0.84. And the IFR should be greater than 0.89 in terms of normal flow. So among patients with impaired post-PCI IFR, 81% had untreated focal stenosis that were angiographically inapparent, and 18% had diffuse disease. If you looked at those, 38% of the focal lesions were located inside the stent segment, while 31% were proximal and 30% were distal. So why are we not getting optimal results for our PCI? And there's 4 main categories. One, there's either a focal residual stenosis or there's diffuse disease. If a focal stenosis is seen, adding another stent could improve your FFR post PCI, whereas if you've got diffuse disease, unfortunately, medical therapy is the way to go. If you have a edge dissection, this should be treated with another stent. And if you have stent under expansion, the stent should be post-dilated or stent malposition. So it could help you with deciding whether further optimization is done. This is best done with intracoronary imaging, but the FFR can also help guide you. So if you look at this study, this is still being assessed to see whether this could be helpful, but this is a OCT catheter that can measure flow as well. So you'll get both intracoronary imaging and flow from the same catheter, looking how in terms of how to optimize your PCI results with use of physiology and imaging. Other studies that are being done right now to assess what's a good cutoff for patients. So this is the target FFR trial, in which they randomized about 260 patients to FFR-guided PCI versus an angiogram-guided PCI. And if you achieve the target FFR of greater than 0.9, you've concluded the study. However, if your FFR is less than 0.9, then further optimization is being done, and you are allowed to add either further stent, post-dilate, or use intracoronary imaging to figure out why your results are suboptimal. The results are still pending, but it's leaning towards that this probably is a positive trial. Another trial is the defined GPS, and they're using IFR and image co-registration in terms of optimizing PCI, and the helpfulness of the defined GPS is using the image co-registration to see where the drop in your pressures are. Is it a diffuse disease, or is it a focal lesion that's causing this suboptimal results? And the estimated completion trial date is March 2025, and they're looking to randomize about 3,200 patients, and their primary outcome is MACE. In terms of using FFR to guide with a bifurcation strategy, if you look at the Euro Bifurcation Club, their statement says provisional approach to bifurcation stenting is the gold standard approach. Despite that, there are some bifurcations that need a dedicated bifurcation approach. I'd like to present this case where a patient had a mid-LAD lesion with a Medina 111 classification, meaning that the main branch is diseased and the side branches diseased, both having disease greater than 50%. So a provisional approach was tried first, where the LAD was wired, the second diagonal was wired as well, and PCI was performed to the main branch. After PCI has been completed to the main branch, the wire from the side branch was pulled back, and assessment of the side branch was made. And as you can see, the side branch is a bit worsened, and this phenomenon occurs due to a combination of spasm, thrombus, stent struts, plaque shift, or carina. And as you can see, there's intra-observer variability between calling the lesion. So observer number 1 called it 70%, while number 2 called it 90%, and number 3 called it 75%. So it's difficult to assess these side lesions or side branches post-PCI and whether it's significant or not. They decided not to perform a dedicated bifurcation strategy for this patient, but sent the patient for a PET scan to look for inducible ischemia. And as you can see, there's no inducible ischemia, so they continued the provisional approach, and the patient did well with no chest pain. If you look at the data for using FFR to guide bifurcation strategy treatment, there isn't a lot of data, but this is one of the big studies in which physiological assessment of provisional side branch intervention strategy for bifurcation. This was done in South Korea. They had 108 patients random on a registry trial for provisional approach PCI. FFR assessment was done of side branches post PCI, and if you had a result less than 0.75, then a balloon angioplasty was performed. And they compared their outcome to 110 patients who underwent angiogram-guided bifurcation strategy, and they showed similar results in terms of MACE and MI. But the importance of this is when you undergo a provisional approach PCI, you're using less dye, the complication rates are lower, your the procedure time is less, and maybe if you're looking at 5-10-year outcome data, the rates of ISR are probably lower for a provisional rather than a bifurcation. So in terms of measuring FFR, we've talked a lot about the in the cath lab FFR, but there are other modalities where we can measure FFR. The biggest is being CT-derived FFR. There are multiple companies that are developing the software now. It's still not mainstream, but we're hoping that in the future that we'll get both anatomical and physiological assessment prior to the patients arriving to us in the cath lab, and this will help guide our management. The other modality I'd like to speak about is the angiogram-derived FFR. It's still under investigation, but what they do is that they take a software and they are able to measure FFRs based on just angiograms, and this would be helpful for operators that are not interventional cardiologists and are unable to do intercourse physiology, and we'd get these results quite quickly in the cath lab. And if a PCI needs to be performed, another operator can jump in and perform PCI. So in terms of use of intercoronary physiology for coronary microvascular dysfunction, it's important to assess patients as a whole. And if you see angina and dyspnea are common complaints between our patients, and 50% of patients referred for coronary angiogram have non-obstructive coronary artery disease. This is a registry data from Denmark looking at 11,000 patients with angina who were referred for a coronary angiogram between 1998 and 2009, and 32% of men versus 65% of women had non-obstructive coronary artery disease despite them having angina and dyspnea. And if you looked at their outcome of patients with angina without obstructive coronary artery disease, it portends a poorer prognosis, meaning that there is something going on that we might be able to help these patients with. And as I told you, showed you before, looking at our PCI results, we might be having patients that have refractory angina after PCI. Even though you've optimized your revascularization, this might be due to a coronary microvascular dysfunction. And as I showed you in our first case, the risk factors for CMD are very similar to patients with obstructive coronary artery disease. So this is a paper published in 2009 looking at CMD in patients that had obstructive coronary artery disease. So they did a 2-year follow-up in 543 patients with stable coronary artery disease treated with PCI, and they measured their IMR at PCI. And they used a cutoff of greater than 21 for their IMR. And if you had a higher IMR after PCI, overall, this meant that they are at higher risk of death or spontaneous MI when you compare them to a group with a lower IMR. So I'm going to try to prove today that a normal coronary angiogram does not equal to a normal coronary vasculature. And this is because when we do a coronary angiogram, we're only looking at 5% of the coronary tree. We're only looking at the epicardium. Whereas if you look at the image to the right, you see the coronary vasculature after a cast mold has been done, and we're not seeing all the microvasculature related to the coronary arteries. So this can be assessed by an invasive and non-invasive approach, PET being the most well-studied, and a diagnostic threshold of less than for a diagnostic threshold of a CFR less than 2. Whereas if you look at the invasive, what we can do in the cath lab, we can measure CFR and IMR. So what's the clinical criteria for suspecting CMD? So it's symptoms of myocardial ischemia, either chest pain on exertion or shortness of breath, and absence of obstructive coronary artery disease, meaning that the coronary artery has a diameter less than 50% stenosis, or a IFR or an FFR that is negative. And then you have to prove objective impairments in coronary microvascular function, meaning a CFR less than 2 or an IMR greater than 25. So going back to our second case, this is a 54-year-old gentleman with typical angina, progressive over several years. A risk factors: a smoker, diabetes, hypertension, exactly similar to patients with coronary artery disease. Presents to the emergency department 3 times over 8 weeks with negative troponin. And as I've showed you, is non-obstructive coronary artery disease, but his flow is sluggish. So intercourse physiology was decided to be performed. The FFR measurement was negative for this patient. So IMR was measured. So a wire was passed through the LAD, and hyperemia was induced by adenosine. As you can see, the PD pressure is 85, whereas the hyperemic transient time was 0.81. And if you put that into the equation, their IMR is greater than 68, meaning that this patient has CMD. And I'll go through how to measure these. So what's the index of myocardial resistance? It was first described in 2003, and it's defined as change in pressure across microvasculature divided by myocardial flow. It leverages the ability of the sensor pressure wire from Abbott to act as a thermostat and also measure temperatures. And then you get the mean transient time of room temperature saline injected into a coronary artery. And this can be determined by a thermodilution curve. And once you've got that, you can get the IMR. So a normal IMR is less than 25. It is very reproducible and is and had superior reducibility and less hemodynamic dependence than CFR. So they've tried multiple trials in which they give patients dobutamine, pacing, and the IMR has always been stable, whereas the CFR results are less reliable. Is very similar to your FFR reliability, and it has a low inter-observer variability. There are pitfalls to measuring IMR though, so it might be inaccurate in the presence of significant epicardial stenosis. So if your FFR is less than 0.75, the patient should be treated with PCI first. So this is an algorithm for assessing patients with CMD and how to diagnose them. So if the patient presented like our patient with chest pain and they got referred for coronary angiogram first, you can rule out the obstructive coronary artery disease. If that has been ruled out, then you can perform coronary vasomotor testing. And if that's positive, then the patient has CMD, while if it's negative, the patient can be discharged from cardiology and deemed to have non-cardiac chest pain. Whereas if you want for a structural stress test first, such as an exercise, if that's positive, you refer them for a coronary angiogram. If it's negative, you can perform PET. If the PET is positive, the patient is referred for a coronary angiogram to rule out obstructive coronary artery disease. Once that has been ruled out, you can diagnose a patient with CMD. If you look at the European Society of Cardiology, they have a Class 2A recommendation for measuring CFR and IMR and the cath lab for patients that are presenting with persistent symptoms but have angiographically normal arteries with a negative IFR or FFR. So this is slowly gaining traction for microvascular angina. This is the landmark Formica trial looking at medical therapy versus an invasive functional testing in angina. And what they did was randomize about 151 patients to either an invasive group strategy of workup versus a allocated control group. And this is the algorithm they use. So everyone went for an invasive coronary angiogram to rule out obstructive coronary artery disease. If no obstructive coronary artery disease was documented, then a pressure wire assessment was done with inducing hyperemia with adenosine. If they had normal physiology over here, then vasoreactivity testing was done by acetylcholine to induce spasm. If you prove spasm, then diagnostic of vasospastic angina was concluded that they recommended smoking cessation, calcium channel blockers, or nitrate. Whereas if the coronary microvascular dysfunction was documented with an impaired IMR or impaired CFR, the microvascular angina was diagnosed, and you can start the patients on beta blocker, lifestyle changes, and maybe consider ACE inhibitors or statin. And if all these tests were negative, the patient had non-cardiac chest pain, they stopped all their anti-anginas and was discharged from cardiology and referred for another specialty to further investigate their chest pain. And this is the results of the core market trial showing that the angina summary score was in favor of the intervention group rather than favor in the control group. And this was theorized to be for multiple reasons. One is the patient felt like they were being fully investigated and their angina was, the doctors were listening to their symptoms. Two, they were more likely to be compliant once you have a diagnosis rather than being told that they have angina and these are the medications that they should be taking. So compliance was much higher in the intervention group versus the control group. This is the last topic I'm going to be talking about, use of IMR and STEMI. We know that patients with coronary artery disease develop coronary microvascular dysfunction, but what about in the acute phase? So this study was published about 5-6 years ago, looking at the prognostic value of IMR measured after primary PCI for coronary intervention, and they had 253 patients with their IMR assessed post-primary PCI. And if you look at their data, they found out that if your IMR was greater than 40, it was associated with an increased risk of death or rehospitalization for heart failure and/or death alone. Unfortunately, we still don't know what to do with this data. It's an independent marker of worse prognosis, but what can we do about it? So there's a study being conducted right now in Sydney, Australia, looking at this. So it's a study of low-dose intracoronary thrombolytic therapy in STEMI, and it's called the Restore MI trial. And it's estimated to enroll about 800 participants in a randomized 1-to-1 fashion. Their inclusion criteria includes STEMI and an IMR greater than 32. The primary outcome is cardiovascular mortality or rehospitalization for heart failure 24 months, and their estimated completion date is December 2023. So this would be an interesting trial to look if intracoronary thrombolytics for patients specifically that have a high IMR would be helpful. So my take-home messages today is intercoronary physiology assessment of coronary artery disease has become one of the cornerstones of interventional cardiology. FFR is still the gold standard in assessing physiological assessments of obstructive coronary artery disease, and CFR and IMR can be used to diagnose CMD in the cath lab. And the use of intercoronary physiology is still limited and restricted by multiple factors, unfortunately, and we still need to go through and try to improve our use of intercoronary physiology in the lab. Thank you.
So thanks very much, Mohammad. I've just been monitoring the Q&A panel. So just a reminder for anyone who has any questions to use the Q&A rather than the chat line. There's a question here, Mohammad, if you want to take it, or if you can't, then I will, as in, what's the optimal therapy for microvascular angina according to the COMICA trial?
So I'll go back here and show you. So their recommendation was a beta blocker, lifestyle changes, weight loss, ACE inhibitor, and statin. Unfortunately, this is still under investigation. There are multiple trials now looking at what is the optimal medical therapy for patients like this. I still, I'm not sure what is the optimal medical therapy. I think we're still in the early phase of trying to diagnose these patients. So I think in the next couple of years, we'll have a better optimal medical therapy for these patients.
I'll just add to that. So as you can see, cardiac rehabilitation is one of the approaches as well. Clinical psychologists would help a lot in terms of reassurance and how to manage the pain. And it's recent that Canada now has ranolazine extended release form as a second line or even an add-on for the management of microvascular disease. I've had variable success with ranolazine in the UK, but now that it is available, well, I know it's going to be available in Canada in April, and let's see what people get more experience with it. I'm just going to give a few more minutes to see whether there are any further questions. While waiting, what I would add to Mohammad's excellent presentation is that most people might say that the data presented today comes from randomized control trials. and that there is little in terms of real-life data. So if you look at a recent publication from Ontario itself, of which Derek is one of the co-authors, this is real-life data that if it confirms the FAMES data that you stent if the FFR is less than 0.8, but more importantly is if you stent a vessel that has an FFR greater than 0.8, you actually do the patient harm. So I think that is very important, and it also highlights how important the FFR is becoming a mainstay of how we treat patients. Now I'm also looking at the other questions, the role of pharmacologic stress PET in diagnosing microvascular dysfunction. If the flow studies are not available, how does it correlate with cath flow studies? So fortunately, I have Dr. Beatons on the line as well, but I'll answer that. So in PET, we have actually what is more appropriately termed the myocardial flow reserve, because what they're measuring is actually the enhancement in the myocardium itself rather than the vessel. So I think it's appropriate that we have changed the terminology to MFR rather than CFR in the PET world. They can measure that, but the one thing that the intracoronary or invasive method of measuring is that the new index of IMR, which is the index of microcirculatory resistance. There are equivalents in PET scans, but it's not as widely published or used. In terms of comparing MFR and intracoronary CFR, it is operator dependent. The published data would say that the correlation is poor, but based on the studies that we have done at the Heart Institute, when we have limited the operators to a few of us who do it consistently, for Dr. Chi's transplant studies, we come quite close. When it's abnormal, we sort of get, the relationship is robust, but we don't get the same values. So if you say that the PET is going to be 3, I'm not going to get a 3 CFR in the cath lab because I'm measuring vessel specific rather than the territory itself. I think Rob might want to add something.
Yeah, so I agree with your comments, and Young, a great presentation, Mohammed. Thank you so much. It is an emerging problem that we're seeing a lot. I think PET has a value in terms of defining flow and flow reserve. As you pointed out, it's the whole myocardium, so it includes the epicardial stenosis effect as well as the microvascular effect and or diffuse atherosclerosis effect, and they may all be behaving somewhat differently. I think if you're truly suspecting this, I do think that there's value in the invasive measurements, because then you can actually tease out which component is really part of the problem for the flow, and then you can use PET as a means to actually follow the patient for any potential functional changes over time. But we've been liking to get the invasive measurements in some of these people because of the value of the index of microvascular resistance, which is really telling us that there's truly microvascular disease. The other thing that we think that PET may be able to do, and particularly now with our new cameras, we'll be exploring this, is whether we can actually look at subendocardial flow, which may behave differently in certain types of diseases as opposed to diffuse microvascular disease and so on. Anyhow, I think PET has some value there to answer the question, and I think it also has value in follow-up and changes. These are often very difficult patients to make diagnoses for. I'll just make one other addition, is that in terms of vasospastic angina, there's potentially a new study that we'll be undertaking to look at that as well. We don't tend to see it as much as we perhaps used to, but this will be something else that could be a factor for some of these patients, and we'll be exploring. Thanks.
I'll just give another minute or so for any further questions. One of the reasons that I haven't been doing the vasospastic angina in the cath lab is acetylcholine is not readily available in Canada. So in the couple of centers that have started doing them, they're buying the eye drops and then asking pharmacy to make it up to the correct concentration. You can see how people are very reluctant to do that. So one more question, I'll use it as a last question then. If I have a patient with classic anginal symptoms, no CAD on cath, will I now routinely get a coronary physiology study for microvascular disease? I'm not going to advertise that I will be the, that there are a few of us who will do that routinely, but if there is a request specifically for that, yes, I will do them. And I'm trying to update our software and hardware to do that now. So we'll see. There's a new device. So in the past, we used the radial analyzer because there was a lack of interest. Abbott no longer manufactures that device. So I'm trying to get the Corventis system, which is we're in the process of getting. And if that is available to us, then it makes things a lot easier. We can use the very same wire that we measure FFR with to get all those indices. The one thing that I suppose no one's asked, but I will state, is that there is a difference between the IFR, or what we are measuring here is the RFR, which is a full cycle non-hyperemic fractional reserve. And the FFR, there is a discordance in multiple studies of up to 10–15% of patients, and that is a reflection of whether the disease is diffuse or focal. FFR is particularly useful if the stenosis is focal, and we treat it, the FFR normalizes. Where there is a very diffuse or long lesion, often we don't see a nice change in pressure, as Mohammad showed, the sudden rise in pressure before and after the stenosis. We see a very gradual gradient, and in those patients, it's hard to know where to start and stop stenting. And I think part of that is where FAME helped, in the sense that often FFR is negative in those studies, but the RFR or IFR is significant. Okay, with that, I think I don't see any further questions. Let me scroll down. What happened to ergotamine? Strange you should ask that, whoever that is. It's coming back. It's an alternative to acetylcholine, and I know that one center in Quebec is interested in using that, and we may collaborate in that. That's all I will say about ergotamine. Okay, if there are no further questions, then I'll call this to an end. Thank you very much, Mohammad. Well done.
Thank you, Chung.
All right, have a good day.
Thanks, Mohammad.
Thank you.
Thanks, Young, for chairing.
You're welcome. Thanks.
Bye now.